organism. He also developed techniques in sterilization. Proteins and immunoglobulins. Next, we have barriers that limit microbes. These are divided into two, which is the epithelial and mucosal. In the epithelial, we have the integument or the skin. For the mucosal, we have respiratory, gastrointestinal, and urogenital. First, we have the skin. This is the most extensive physical barrier with its own resident microflora that block attachment and invasion of non-commensal microbes. The skin has sebaceous glands and has constant shedding of epithelial cells, keeping the microbes in check. The commensal organisms are gram-positive aerobic microbes, the Staphylococcus, Streptococcus, Corynebacterium, and Propionibacterium. So overgrowth of skin commensal organisms and barrier breaches lead to diseases of the skin. So next is the upper respiratory tract. The upper respiratory tract produces mucus, which traps particles, including microbes, which is then passed into the upper airways and the oropharynx by ciliated epithelial cells. The person then coughs, which clears the mucus. So there are pulmonary alveolar macrophages, which clear small particles that arrive in the lower respiratory tract by phagocytosis. So bronchitis or pneumonia is the result of the diminished host defenses. So next, we have sterile organs in the body. First, we have urogenital, biliary, pancreatic, and distal respiratory tract. So normally, these organs have no commensal organisms and are considered sterile. So what are the diseases that affect host barriers? First, we have malignancy. Next is inflammation. Next is calculi or stones. And lastly, foreign bodies, which can introduce bacteria from an external source like a urinary catheter or aspiration of food particles. Next, we have the normal number of microbes in the alimentary tract. First, we have gastric. It is approximately 10 to the power of 2 to 10 to the power of 3 colony forming units per ml or CFU per ml. In the terminal ileum, we have 10 to the power of 5 to 10 to the power of 8 CFU per ml. And in feces, we have 10 to the power of 11 and 10 to the power of 12 CFU per gram. So next are the common organisms. These are divided into anaerobes or aerobes. For the anaerobes, we have the Bacteroides fragilis, Distassonis, Theatomicron, Bifidobacterium, Clostridium, Eubacterium, Fusobacterium, Lactobacilli, and Peptostreptococcus species. For the aerobes, we have Escherichia coli, Enterobacteriaceae, A. faecalis, E. faecium, Candida albicans, and other Candida species. Next, we have outcomes of microbial invasion. First, there is eradication of the microbes. Next, there is containment leading to pus formation. Next is local regional infection leading to cellulitis, lymphangitis, and an aggressive soft tissue infection. And finally, we have systemic infection, which can lead to bacteremia or fungemia. So what is an infection? An infection is the presence of microorganisms in host tissue or bloodstream. This would manifest with rubor or redness, color or warmth, dolor or pain, plus an elevated temperature, elevated WBC, tachycardia, or tachypnea. Next is systemic inflammatory response syndrome, or SIRS. This is a pro-inflammatory state in response to a variety of disease processes such as infection, pancreatitis, polytrauma, malignancy, and burns. So the classic manifestation is fever, tachycardia, and tachypnea. And usually, organisms with SIRS warrants further investigation since they experience physiologic stress. Next, we have a table showing the criteria for SIRS. First, we have general variables with fever of more than a temperature of more than 38.3 degrees Celsius, hypothermia with a temp of less than 36 degrees Celsius, heart rate of more than 90 beats per minute, tachypnea, altered mental status, significant edema or a positive fluid balance of more than 20 ml per kilo over 24 hours, and hyperglycemia in the absence of diabetes. For the inflammatory variables, we have leukocytosis of more than WBC of more than 12,000, leukopenia with a WBC of less than 4,000, a bandemia of more than 10% band forms, plasma C-reactive protein of 2 above the normal value, and a plasma procalcitonin with a 2 above normal value. For the hemodynamic variables, we have arterial hypotension with an systolic blood pressure of less than 90 mmHg, MAP of less than 70, or a decrease in the systolic blood pressure or more than 30 mmHg. Next, we have organ dysfunction variables. First, we have arterial hypoxemia. Next, we have acute oliguria, creatinine increase, coagulation abnormalities, ileus, thrombocytopenia, and hyperbilirubinemia. Next is the tissue perfusion variables. So we have hyperlactemia and a decreased capillary filling. Next is sepsis. This is a cascade of pro-inflammatory mediators produced in response to exposure of microbial products. This is a life-threatening organ dysfunction caused by a dysregulated host response to infection. So organ dysfunction is quantified as an increase of more than 2 points on the sequential organ failure assessment. So for the sequential organ failure assessment score, or the SOFA, we have 6 organ systems, namely respiratory, coagulation, hepatic, cardiovascular, CNS, and renal. For the respiratory, we have the PaO2 or FiO2 ratio. For the coagulation, we have platelets. The hepatic, we have bilirubin levels. For the cardiovascular, we have MAP measurements or the need of pressors. For the CNS, we have the GCS score. For the renal, we have the measurement of the serum creatinine and rene output. Next, we have the quick sequential organ failure assessment, or the QSOFA. This is an abbreviated version of the SOFA. So potentially life-threatening sepsis when at least 2 of the following parameters are met, namely altered mental status, systolic BP of 100 mmHg or less, and an RR of 22, more than 22 beats per minute. So this readily identify patients at risk of poor outcomes for sepsis. Next is septic shock. This is defined as a profound circulatory and cellular metabolic derangement. So this is the most severe manifestation of infection with a mortality rate of 40%. This is defined as a persistent arterial hypotension requiring vasopressors. So what are these microbes that cause infection? First, we have bacteria. These are responsible for majority of surgical infections. So we have gram-positive, gram-negative, aerobic, and anaerobic. For gram-positive, we have the Staph aureus and epidermidis, Staph pyogenes, E. faecalis, and faecium. So these cause a large percent of surgical site infections. The enterococci can cause nosocomial infections in immunocompromised or chronically ill patients. Next, we have the gram-negative. We have the Enterobacteriaceae, such as E. coli, Klebsiella pneumonia, Serratia marcescens, Enterobacter, Citrobacter, Acinetobacter, and Pseudomonas. For the anaerobic, they divide poorly and unable to grow in air since they don't have the enzyme catalase. So these are indigenous flora such as your Propionibacterium acnes, which is a skin microflora and can cause acne. So also the microflora of the oropharynx and the colon. Other examples are the acid-fast bacilli such as the Mycobacterium tuberculosis, Mycobacterium avium intercellulare, Mycobacterium leprae, and Nocardia. So these are slow growing organisms. Next are the fungi. These are identified by use of special stains such as potassium hydroxide, India ink, methylamine silver, or Gemsa stain. So these have branching and septations, and they grow at a different temperature at 25 degrees Celsius. So these usually cause nosocomial infections as part of a polymicrobial infection or fungemia. Next are viruses. So viruses are difficult to culture, and viral infections occur in the immunocompromised host. So we have the adenovirus, cytomegalovirus, Epstein-Barr virus, herpes simplex virus, varicella zoster virus, hepatitis B and C virus, and HIV. Next, we have prevention and treatment of infections. First, we have prophylaxis, which are maneuvers to diminish presence of microbes. These are divided into mechanical and chemical. For mechanical, we have hand washing or hand scrubbing. For chemical, we have the alcohol-based antiseptics, antibiotics. Next is patient preparation. So we usually start preparing the patient the night prior to the planned surgical procedure. So the patient usually gets a full head and body bath or shower using soap or an antiseptic agent. Hair removal from an operative site using clippers is used rather than razors to avoid creating nicks in the skin that can foster bacterial growth. And also, the skin should be cleansed with an alcohol-based antiseptic agent. A preoperative antimicrobial therapy should be given, allowing bactericidal concentration of the agent in tissues before the incision is made. So we usually give preoperative or prophylactic antibiotics an hour prior to the incision. And the intraoperative maintenance of euglycemia with a glucose of less oxygenation. Next is source control. Source control is the drainage of all purulent material, debridement of all infected, devitalized tissue and debris, and or removal of foreign bodies at the site of infection. The goal is remediation of the underlying cause of infection. An abscess is a walled-off purulent fluid collection which is usually treated by incision and drainage. An ongoing source of infection, such as a bowel perforation, is managed by resection or repair of the perforation. An aggressive, rapidly spreading infection, such as a necrotizing soft tissue infection, should undergo emergency debridement. And a delay in operative intervention is associated with an increased morbidity and occasional mortality. Next, we have the appropriate use of antibiotics. First, we have prophylaxis. This is administration of an antimicrobial agent or agents prior to the initiation of a surgical procedure to reduce the number of microbes that enter the tissue or body cavity. This is limited to the time prior to and during the operative procedure. and a prolonged procedures in which the duration exceeds the half-life, so the patient should receive an additional dose of antibiotics. Next, we have examples of prophylactic antibiotics. So for cardiovascular surgery, we usually give cefazolin and cefuroxime. And for patients allergic to penicillin, we give vancomycin and clindamycin. For patients undergoing surgery in the gastroduodenal area or a non-obstructive small intestine surgery, we give cefazolin and clindamycin or vancomycin plus an aminoglycoside or aztreonam or fluoroquinolone as an alternative. For the biliary tract, a laparoscopic high risk or an open procedure, we give cefazolin, cefoxitin, cefotetan, ceftriaxone, or ampicillin sulbactam. The alternative is clindamycin, vancomycin plus an aminoglycoside or aztreonam or fluoroquinolones, or also metronidazole plus aminoglycoside or fluoroquinolone. For a low-risk laparoscopic biliary surgeries, we usually don't give prophylactic antibiotics. For uncomplicated appendectomies, we give cefoxitin, cefotetan, aminoglycoside, or aztreonam or fluoroquinolones, or metronidazole plus aminoglycoside or fluoroquinolones. For colorectal surgeries with or in obstructed small bowel, we give cefazolin or ceftriaxone plus metronidazole, ertapenem, cefoxitin, cefotetan, ampicillin sulbactam. An alternative is clindamycin plus an aminoglycoside, aztreonam or fluoroquinolones, metronidazole plus aminoglycoside or fluoroquinolones. In head and neck surgeries, we usually give cefazolin, cefuroxime, clindamycin, and vancomycin as an alternative. For orthopedic surgeries, we have cefazolin and ceftriaxone, with alternatives still with clindamycin and vancomycin. For breast and hernia surgeries, we give cefazolin and clindamycin and vancomycin as an alternative. So next is empiric therapy. This is defined as the use of an antimicrobial agent when the risk of a surgical infection is high and based on the underlying disease process or when there is significant contamination during surgery. So usually this is limited to a short course to 3 or 5 days. So therapy for monomicrobial infections, for UTI we have 3 to 5 days. Pneumonia, we have 7 to 8 days. Bacteremia, we have 7 to 14 days. Osteomyelitis, endocarditis, or prostatic infections, we have 6 to 12 weeks. So, longer courses of therapy do not result in improved care and are associated with increased risk of superinfection by resistant organisms. So, we consider eradication of an intra-abdominal infection when we already have an absence of an elevated WBC count, lack of band forms or polymorphonuclears on peripheral smears, or lack of fever or less than 38 degrees Celsius. So procalcitonin is also a useful information or laboratory regarding whether an infection has resolved. Patients who don't improve with 5 to 7 days of antibiotic therapy should be reevaluated for inadequate source control or a new extra-abdominal source of infection. Next is an allergy to antimicrobial agents. So it is important to ascertain whether the patient has had any type of allergic reaction in association with administration of a particular antibiotic. So the most common is a penicillin allergy, occurring in 0.7% to 10% of the population. So some centers perform intradermal testing to see if a patient is allergic to a specific antimicrobial agent. Next, we have surgical site infections. So this is defined as an infection of the tissues, organs, or spaces exposed by surgeons during performance of an invasive procedure. These are incisional or organ space infections. For incisional, we have superficial and deep, and for organ or space infections, we have an incisional SSI, which occurs in a surgical wound which drains purulent material, or if the surgeon judges it to be infected and opens it. So, what are the factors related to the development of surgical site infections? First, we have the degree of microbial contamination of the wound during surgery. Next is the duration of the procedure. And next is the host factors such as diabetes, malnutrition, obesity, and immune suppression. So this is a table showing the risk factors for development of surgical site infections. So we have the patient factors, local factors, and microbial factors. For patient factors, we have old age, immunosuppression, obesity, diabetes mellitus, chronic inflammatory process, malnutrition, smoking, renal failure, peripheral vascular disease, anemia, radiation, chronic skin disease, chronic states such as chronic staphylococcus carriage, and recent operation. Factors we have open compared to laparoscopic surgeries, poor skin fracturation, contamination of instruments, inadequate antibiotic prophylaxis, a prolonged procedure, local tissue necrosis, blood transfusion, hypoxia, and hypothermia. For microbial factors, we have prolonged hospitalization leading to nosocomial organisms, toxin secretion, and resistance to clearance such as capsaicin. So this is a table showing the risk factors for development of surgical site infections.
Clean wound.
So we
So there is
have
no
the patient
infection
factors,
present,
local factors,
and
and
only skin
microbial factors.
microflora can
For patient
potentially
factors, we have old
contaminate the
age,
wound,
immunosuppression,
and no hollow
obesity,
biscuit.
diabetes
So how do we
mellitus, chronic
manage these
inflammatory
wounds?
process,
For class 1 and
malnutrition,
class 2,
smoking, renal
these
failure,
wounds may be closed
peripheral vascular
primarily.
disease,
For class
anemia,
3 and class
radiation,
4,
chronic skin
closure leads to a
disease,
high rate of
chronic
incisional
states such
surgical
as
site
chronic
infection,
staphylococcus
ranging up
carriage,
to 25 to
and recent
50%.
operation.
And studies show that class 3 wounds in healthy patients can be closed primarily as long as an antibiotic therapy is directed against aerobes and anaerobes with an SSI rate of 3 to 4%.
Local tissue necrosis,
So
blood
effective
transfusion,
therapy is
hypoxia,
solely
and
incision
hypothermia.
and drainage
For
without
microbial factors,
additional
we have
use of
prolonged
antibiotics,
hospitalization
with the
leading to
wound left
nosocomial
open and
organisms,
allowed to
toxin
heal by
secretion, and
secondary
resistance to
attention.
clearance such as
Antibiotic therapy is given or reserved for patients in whom evidence of significant cellulitis is present or patients who manifest an SIRS. So you usually obtain wound cultures in patients who develop SSI.
Next are intra-abdominal infections. This is defined as microbial contamination of the peritoneal cavity or peritonitis. So first we have primary microbial peritonitis. So the microbes invade the normally sterile peritoneal cavity via hematogenous dissemination from a distant source of infection or direct inoculation. This is common in patients with ascites or patients undergoing peritoneal dialysis, and usually this is monomicrobial and rarely requires surgical intervention. So the typical findings of a diffuse tenderness and guarding without localizing signs, an absence of a surgically treatable source of infection on imaging study, with a more than 250 neutrophils per ml in the acidic fluid, and cultures are typically gram-positive organisms. So the antibiotic coverage directed against the microbes for 14 to 21 days and the removal of indwelling devices such as the peritoneal dialysis catheters. So next is the secondary microbial peritonitis. This is contamination of the peritoneal cavity due to perforation or severe inflammation and infection. So these are usually polymicrobial. An example of which is appendicitis, paloviscous perforation, and source control to resect or repair the diseased organ, debridement of necrotic tissue or infected tissue and debris, and administration of antimicrobial agents directed against aerobes and anaerobes are the management of secondary microbial peritonitis. So a combination of antibiotics or single agents with a broad spectrum of activity
is given until exploratory laparotomy is performed to establish the diagnosis. So, effective source control and antibiotic therapy is associated with low failure rates and a mortality rate of 5 to 6%. So, we have a mortality rate of more than 40% if we are unable to achieve source control. So, majority of abscesses can be effectively diagnosed with an abdominal CT scan and can be treated by percutaneous drainage. So, surgical intervention is reserved for individuals who harbor multiple abscess, whose abscess is in proximity to vital structures or areas that can't be accessed via a perc drainage, or in patients with an ongoing source of contamination, such as a perforated bowel. So, a short course of antibiotics with aerobic and anaerobic coverage is given, and the drain should be left in situ until it is clear that the cavity has collapsed or if the output is less than 10 to 20 cc per day. And there is no evidence of ongoing source of contamination, and the patient's clinical condition has improved. Next is hepatic abscess. So this is a rare phenomenon. So this is pyogenic in 80% of cases, and in 20% of cases, this is caused by parasitics and fungal infection. So the most common cause is manipulation of the biliary tract, and the most common aerobic bacteria are E. coli, Klebsiella pneumonia, Enterococci, and Pseudomonas. So the most common anaerobic bacteria are the Bacteroides, anaerobic Streptococci, Fusobacterium, and Candida. So for small abscesses less than 1 centimeter or multiple abscesses, these are sampled and treated with a 4 to 6 week course of antibiotics. For large abscesses, they are amendable to percutaneous drainage, and with recurrent abscesses requiring operative intervention like unroofing and debridement. Splenic abscess is rare and has the same treatment as an hepatic abscess. For skin and soft tissue, we usually these are superficial infections causing cellulitis, erysipelas, and lymphangitis, which are treated with antibiotics alone. So furuncles or boils may drain spontaneously or need surgical incision and drainage. Antibiotic is only needed if there is significant cellulitis or if cellulitis does not resolve after drainage. So MRSA should be suspected if the infection persists after treatment with adequate drainage and administration of antimicrobial agents. Next, we have aggressive soft tissue infections. So these are rare and are difficult to diagnose. They require immediate surgical intervention plus antimicrobial agents, and failure to rapidly recognize results in extremely high mortality, reaching up to 80 to 100%. And even with expedient therapy, mortality remains high, reaching up to 16 to 24%. So the most commonly affected areas are the extremities, perineum, trunk, and torso. So the patients at risk are the elderly, immunocompromised, diabetics, and patients with peripheral vascular diseases. So the pertinent findings are grayish, turbid, semi-purulent material or dishwater pus. So skin changes such as bronze hue or brawny induration, blebs or crepitus, and pain at the site of infection out of proportion to any physical manifestation. And usually they require multiple debridements to completely remove the infected tissue, and the antibiotic should be tailored to the results of the culture and sensitivity. So patients with gas-forming organisms or Clostridium perfringens infection should be given hyperbaric oxygen therapy. So next are post-operative nosocomial infections. Surgical patients are prone to a wide variety of nosocomial infections. such as surgical site infection, urinary tract infection, pneumonia, and bacteremia. So, urinary tract infection is considered based on a urinalysis demonstrating WBC or bacteria or positive test for leukocyte esterase. So, it is diagnosed as a more than 10 to the power of 4 CFU per ml in symptomatic patients and 10 to the power of 5 CFU per ml in asymptomatic patients. So, usually it is a 3 to 5 day treatment, and post-op patients should have the indwelling catheters removed as early as possible. Next is pneumonia. So, it is usually present in patients with prolonged mechanical ventilation. It presents with more severe diseases and are more likely to have drug resistant pathogens. So, the presence of a purulent sputum, elevated leukocyte count, fever, and a new chest x ray abnormality establishes the diagnosis. The presence of flu clinical findings plus chest x ray findings increases the likelihood of pneumonia, and surgical patients should be weaned off from MECVENT as soon as possible. Next, we have central line catheter infections. So these devices are used for monitoring vascular access, such as access for hemodialysis, drug delivery, and hyperalimentation. So around 25% of patients become colonized, and 5% of these patients are associated with bacteremia. The patients are usually asymptomatic, often exhibiting an elevated WBC, and blood cultures obtained from the peripheral site and catheter increases the index of suspicion. So, obvious purulence, severe sepsis, and bacteremia fungemia should lead to catheter removal, and a 14 to 21 day of antibiotic course is given. Lastly, we have the surviving sepsis guidelines. So, initial resuscitation. So, we begin resuscitating immediately in patients with hypotension or an elevated serum lactate, with a resuscitation goal of at least 30 ml per kilo IV crystalloid given in the first 3 hours. So, ongoing fluid administration should be guided by physiologic response as measured by clinical variables such as the heart rate, blood pressure, and urine output, and or other invasive or non-invasive monitoring. Resuscitation goals include mean arterial pressure of more than 65 mmHg, urine output of zero point 0.5 ml per kilo per hour, and a mixed venous oxygen saturation of more than 65%. So the target resuscitation to normalize lactate in patients with elevated lactate levels. So one should also obtain appropriate cultures prior to antibiotic therapy, but one should not delay giving antibiotics, and also imaging studies should be performed promptly to confirm the source of infection. For antibiotic therapy, begin antibiotic therapy as early as possible and within the first hour after recognition of the severe sepsis or septic shock. So use broad spectrum antibiotic regimens with penetration into presumed source and reassess regimen daily with de-escalation as appropriate. And discontinuation of antibiotics in 7 to 10 days for most infections, and stop antibiotics for non-infectious issues. And also consider the use of serial procalcitonin levels, which may allow earlier cessation of antibiotic therapy. Next is source control. So one should establish an anatomic site of infection as rapidly as possible and implement the source control measures as soon as possible after initial resuscitation. So remove the intravascular access devices if potentially infected. So fluid resuscitation should start using crystalloids with continued fluid challenges so long as hemodynamic parameters continue to improve, and also if the patient remains fluid responsive. Albumin may be used as an adjunct if large volumes of crystalloids are required for vasopressor or anisotropic therapy. So we should maintain a MAP of 65 mmHg And centrally administered norepinephrine is the first line choice. And vasopressin should be added if needed to raise the mean arterial pressure or to reduce norepinephrine requirement. Epinephrine is an alternative to vasopressin but has a greater risk of reduced splanchnic blood flow. Dopamine is an appropriate alternative only in select patients, such as patients with bradycardia or low risk of arrhythmia, and there is no role for low dose renal protection dopamine. Phenylephrine is not recommended, and insertion of an anterior catheter for patients requiring vasopressors to monitor the arterial blood pressure. Consider dobutamine infusion for persistent hypotension after appropriate resuscitation and use of a vasopressor agents. Steroids should also be considered with a dosage of less than 30 milligrams per day for adult patients in septic shock when hypotension responds poorly to fluids and vasopressors. Next, we have administration of blood products. So red blood cells should be transfused when the hemoglobin decreases to less than 7 grams per deciliter in the absence of extenuating circumstances such as myocardial infarction or hemorrhage. It is not necessary to use FFP to correct the INR abnormalities in the absence of bleeding, and one should also consider giving prophylactic transfusion of platelets when the counts are less than 10,000 in the absence of bleeding, less than 20,000 if there is a risk of bleeding, and less than 50,000 in the setting of active bleeding or the need for a procedure. So next are the other supportive treatments. For the mechanical ventilation, so the target initial tidal volume of 6 ml per kilo body weight and a plateau pressure of less than 30 cm H2O in patients with acute lung injury should be maintained. And the use of PEEP to avoid lung collapse should be done and adopt a conservative fluid strategy. In the setting of sepsis-induced ARDS, with a PaO2 or FiO2 ratio of less than 150, a prone ventilation should be given over continued supine position or high-frequency oscillatory ventilation. So use of weaning protocol to evaluate the potential for this continuing mechanical ventilation should be done, and pulmonary artery catheter placement is not indicated for patients with a target blood glucose of less than 180 mg per dl should be achieved. And for prophylaxis, the use PPIs or H2 blockers for stress ulcers and low dose unfractionated or fractionated heparin to prevent deep venous thrombosis. Then one should also discuss the advanced care planning with patients and families and set realistic expectations.
So that's for cervical infection. Thank you. So if ever you have any questions, please feel free to ask.